Hello, everyone. Welcome to Webinar 3 in our series, HIV and Poverty, How to Manage and Confounding Syndemics. My name is Brenda Farrow, and I'm a project analyst of the Abandoned Infants Assistance Resource Center. Today's webinar is presented by Dr. Victoria Cargill. Dr. Cargill is Director of Minority Research and Director of Clinical Studies in the Office of AIDS Research at the National Institutes of Health. She is the author of numerous scientific articles and analytical essays, and she has appeared on local and national programs such as Morning Edition on NPR and in popular magazines like Ebony and Newsweek. She teaches at the University of Pennsylvania Robert Wood Johnson Scholars Program, and she continues to care for people living with HIV and other general medical problems as a volunteer physician in Southeast Washington, D.C. Dr. Cargill has been named one of America's top physicians consistently for the past 7 years. Before we start, I'd like to remind you that you can ask questions using the chat feature in the lower left portion of your screen. We will leave some time at the end of the presentation for questions, but please feel free to chat your questions in at any point. And now I'd like to turn it over to Dr. Cargill. Dr. Cargill, thank you for being here with us today.
Well, thank you so much, and I'm really looking forward to what I hope will be an interactive time together. So while we're all sitting and looking at our computers, I hope you are in a place where you can sort of take a deep breath. The work that we do is very taxing, and relax, so that we can, what I think is probably really talk together about what is something that confounds our attempts many times to have the best outcomes possible for our clients and our patients. Before I start, and so to get everybody kind of loosened up a little bit, I want to just take a couple of quick show of hands. So how many people are, and this isn't where you currently are, but just to give us a sense of your background, how many people are from the Northeast? That would be from like Maine down to New Jersey. Just raise your hand quickly. Okay, and that's good. Oh, even more. Great. My Boston accent will come out from time to time, alternating with my New York accent, so I'll feel right at home. How many people from the Southeast, let's say from Delaware and Pennsylvania on down to Florida? All right. Oh, I see one. Okay, anyone from between, let's say, West Virginia and Ohio all the way to the Rockies? Denver, Montana there. All righty now. Great. And then West Coast. Washington, Oregon, California, on down. Whoa. Fantastic. Thank you. Oh, they keep on coming. Excellent. Thanks. So what I thought we'd do today is go ahead and talk about poverty, talk about HIV, and then talk about how these really confound each other. So I'm going to go ahead and start. I have to give my disclosures, and first of all, I have no financial disclosures to make. I'm not selling anything. I'm not trying to sell anything. And the last part of this is what I would call my I'm allergic to unemployment statement, which is basically I need to tell you that the views that I'm going to express during this presentation are strictly mine. They don't represent the Department of Health and Human Services, the National Institutes of Health, or the Office of AIDS Research, where I am currently employed. So with that, I'm going to take the pastor's approach in a way. I'm going to tell you what I'm going to tell you. I'm going to tell you, and then at the end I'll summarize and tell you what I told you. So as you can see here, the goals of the presentation are pretty straightforward. I want to make sure we identify those populations that unfortunately fall right between the crosshairs of both poverty and HIV infection. We're going to talk through a bit about how poverty certainly confounds the HIV epidemic. Show again some demonstrations of how poverty and race exacerbate conditions that certainly facilitate HIV acquisition, transmission, and unfortunately poor treatment outcomes. And I'm going to walk through a couple of cases of people I've recently cared for with you. And then finally, we're going to identify some practical strategies to try and negotiate this quagmire that we sometimes find ourselves in when poverty and HIV conspire to make treatment outcomes difficult for both patients and providers. So the first thing is, why are we even talking about poverty? And this is more of a rhetorical question. Everyone on this phone certainly knows why. But because they're overlapping epidemics, and as a reminder that the poor have always been with us, and we see that even in John, who said, you have always had the poor with you, but you not always have me. So these are snapshots of poverty in America. For the most part, they are current through September 30th, 2015. If they are not, I will indicate that so that you will know that this is not the most current data, but pretty much the data that I'm providing to you is the most currently available data. So we're talking about a snapshot of poverty in America, and as we all know, the economy has continued to contract. It is very difficult. There are about 48 million Americans, almost 15% of the United States population living in poverty, and this hasn't changed since 2013. There were even more, but even with the Affordable Care Act, we still had, as of last count, which as of September 16, 2015, 33 million people without health care insurance at some point in that last year. About 1 out of every 5 children depends upon food stamps, and 1 out of 1.5 million are what we call the ultra poor. And those are people, and I want you to think about this for a second, these are people, what it would be like to try and live on less than $2 a day. And then when you think about that, think about the fact this number has doubled since 1996. The number of homeless children in the United States has gone up by 60%, and 45%, almost half of all African American children, live in areas of what would be called, according to the U.S. Census, quote, concentrated poverty. It continues in the snapshot. Look at the number of people who depend upon food banks, 46 million. I live in a small state, and our food bank actually ran out of food at one point in the fall. About 1/3 of female head of households live in poverty, and there has been no change in household median income. Again, I remind you, median is not the mean. Median is where most people cluster. There hasn't been a change in the household median income in the United States since 2013, and yet prices have continued to rise. So what that means is everyone, whether you want to or not, has taken a bit of a pay cut. And 1 out of 3 black children and 1 out of 4 Hispanic or Latino children live in poverty in the U.S. Now, this should not come as any surprise, but I want to make sure we don't just focus on race, but also look at gender, because poverty is not equal across age and it's not equal across gender. So if you look at the graph in front of you, again, this is from the U.S. Census Bureau for 2015 when they closed down their numbers. For those under age 18, not surprisingly, males and females are about equal. And along the bottom are the percentages, a little bit over 22%. But once age 18 to 64, you see females begin to outpace males in terms of rates of poverty, with females sitting solidly at 15%. And then when you look again at age 65 and older, again, females outpace males. Now, if you're thinking quickly, you might say, well, Dr. Cargill, we have problems in our communities where there's violence and there's murder and accidents. Even if you account for that, women still lead the pack when we're talking about poverty. It's also not equal across races, and again, this is median household income on the left-hand side of the slide with race ethnicity along the bottom, with blue representing Asian, orange is Caucasian, gray, Hispanic, Latino, yellow, black. And again, median household income doesn't mean the mean, it means where most of the people in that particular group fall, and that is around 73, 74,000 for Asian, all the way down to roughly 35,000 for black. So you can see that, again, there's a number of differential factors that cut here, race as well as gender. Unemployment certainly is tied to race, and these are figures, again, from the Census Bureau, and I've given you 2 snapshots for comparison. The dark blue is for August 2014 rates, and the teal or lighter color is the August 2015 rates. And without getting bogged down in this, I just want you to look at it overall. And if you sit back a little bit and look at this slide, it almost looks like a normal Gaussian distribution. You've got the hump in the center and the outliers on the far sides. So on the far left, you have whites overall and then white males age 20 and older. And on the far right hand, you have Asian overall. Interestingly, the census did not have data yet analyzed to break out Asian male apart from Asian overall. But that notwithstanding, if you look in the middle, the highest unemployment rates by race, and when you break it out by gender for male, is again in black, with Latino right behind, and the two outliers are whites on the left and Asians on the right. Similarly, education is also confounded by race, and we don't have time here to go into that, but a lot of it has to do with how schools are funded. It depends upon a tax base, depends upon the neighborhoods and the population that's there. I don't live very far from Chester, Pennsylvania, and we had a problem in the fall where they were actually considering closing the entire Chester school district and farming all those children out to other districts because they had such a shortfall in what they needed to educate those children. And these are almost 100% race and ethnic minority children, just as an example. So if you look at this slide, education is confounded by race, you will see that if you look at the left, it's high school or more, the middle is some college, to the far right, it's a bachelor's degree or higher. And the blue is the data for 1971, the green data for 2013, and it is divided by non-Hispanic white, black, and Hispanic. And while there were gains for every single sector, high school or more, college or more, bachelor's degree or higher, if you look at the rate at which it drops off much more sharply for black or Hispanic individual young adults, 25 to 29, than it does for whites. So this is just a quick series of snapshots to make the case, and I think convincingly, that poverty not only disproportionately impacts women and children, but also racial and ethnic minority populations, and that's just like HIV infection, so there isn't a surprise that there is an overlap. So now we're going to talk about how this intersection occurs. And unfortunately, I think at times the media tend to portray, or our representatives may sometimes become confused and think that, well, of course poverty and HIV are intertwined and it's, no-brainer and so what. But I think I'm going to try and present to you some data to make the case that it isn't just a simple so what. It really changes the playing field. The first is a study that was done from the Centers for Disease and Control Prevention funded National HIV Behavioral Surveillance System for Heterosexuals. And the reason it's called the HET1 is because it's very different from their young men who have sex with men survey, the YMSM. So this study was done, and Denning and Donito did a very nice job of taking a look at data they collected between September of 2006 and October of 2007, and they focused on several clear criteria. One had to live in a poverty area, and that was defined at living at or below the poverty level through 25 cities that represented the span of the epidemic in the U.S. And you see those cities at the bottom of your slide. They include cities like Boston, New York City, Newark, New Jersey, Philadelphia, Atlanta, etc. The survey covered obtaining information such as the person's demographics, gender, race, age, sexual behavior, drug and alcohol use, HIV testing, prior health histories, including sexually transmitted infection, and whether or not they use prevention services. And everyone was offered an anonymous HIV test, and 98% of the participants consented. And they obtained these people by either using what's called respondent-driven sampling or venue-based. And what that basically means is you now have a study looking at 25 cities for the period of 1 year. People had to be poor, and the way the participants were identified is they either were tested and brought in because they went to a particular location or because someone they knew had participated and said, come on down and participate in the study. So you use networks as well as location as the bottom line. And what you see on this slide is very clear demonstration that poverty was clearly linked to HIV seroprevalence. The higher the income, the lower the HIV positivity rate. And as if that isn't convincing enough, poverty is such a strong indicator that it almost mutes the differential between race. On the left-hand side, you have U.S. poverty levels looking at HIV positivity rates across race. On the right-hand side, you see the U.S. overall. And so what you see is looking at HIV seropositivity rates in these poor areas and these specific cities, it almost muted the differential, as opposed to if one takes overall, which gives a much broader range of income, there again becomes a bigger differential. So that's one way to take a look at it. But what about these poverty areas compared to other places in the world with known high rates of HIV infection? You have here Burundi and Ethiopia representing the lesser developed areas in Africa. You have Angola as well, and then Haiti, which is the poorest country in the northern hemisphere. And what you see is the seropositivity rate in U.S. poverty areas actually rivals every single one of those nations. So now how about women? Let's take a little bit further Conan view and say, okay, we've looked at poverty areas overall, and the BHAT looked at people who behaviorally reported themselves to be heterosexual. What about just women? And this was a trial done and funded by the National Institutes of Health. The HIV Prevention Trials Network conducted. The lead principal investigator, colleague and friend of mine, Dr. Sally Hodder, known as HPTN-064 or ISIS. And the whole point of the study was just to try and estimate overall the HIV incidence rate among women who were at risk for HIV in the U.S. They engaged 2,000 women from very distinct geographic areas, but they were high-risk areas, again, very similar to the previous study. And women would participate in interviews and as well as in focus groups. And the whole objective was to try and get a sense of what was this incidence like among these 2,000 women in geographic areas with a high prevalence of HIV and a high prevalence of poverty. There were over 2,000 women, 88% of whom were black. The initial HIV testing, because women were tested upon entry into the study so that it could be determined who came into the study positive as opposed to who converted during the study. And up front, 1.5% of the women who came into the study were HIV positive, not a one of whom knew of their HIV status. Again, that rivals some of the countries I showed you in a prior slide. When one looked at the incidence during the study, it came out to about 0.24%. And for that particular age group, it was very similar to the HIV incidence rates found in places like sub-Saharan Africa, including the Congo and Kenya. But what I find most striking every time I look at the HPTN-064 data is how much these women died from unrelated AIDS complications. While they had high rates of that, murder, accidents, and suicide were right up there as well, again reminding us that the morbid conditions associated with HIV and poverty don't always have to be just HIV related. So both the BHAT and the HPTN studies demonstrate that there are high rates of drug use, alcohol use, depression, not a surprise to anyone on this phone, hepatitis C, as well as very poor treatment adherence, and very often lesser educational attainment, which unfortunately has been very highly co-associated with health literacy. And the lower the educational attainment, the lower the health literacy, and the lower the health literacy, the poorer the treatment outcomes. So race impacts educational attainment, employment, certainly social and sexual networks, care seeking, and until recently, insurance status. So what you have is this unfortunate but very difficult equation, which is that poverty and race not only equal substantial challenges, but then when one adds HIV infection in that, it becomes even more challenging. Now we have race that also confounds sexual disease history in our nation, and what you're looking at here is Tuskegee. And on the left-hand side, you're seeing a picture of the sharecroppers who are actually waiting for Nurse Ruth to come to finish drawing their blood. You see one of the CDC workers on the far left applying a tourniquet. But what has not often been looked at, and I dug around and at the same time found this photograph from the New York Times literally within weeks of when this sharecropper picture was taken, announcing that they now had penicillin in stock to treat everyone in the area. So once again, this bitter irony and this confounding has been present in our history. And in our present, we have race linking to health access and doing without health care. And this comes from the Kaiser Family Foundation. It was a study they did in 2014 as the Affordable Care Act discussion was really heating up, demonstrating that if one looked at, on your left-hand side of the screen, individuals who had no usual source of care compared to the right-hand side of the screen, and those are individuals who say they went without care because of the cost, you will notice something very similar, and that is that the highest percentage of individuals who said they either had no usual source of care or they went without care because of cost in the age of 8 range of 18 to 64 were Hispanic and Black. So this is really a schematic from one of our papers that talks about the number of intersecting challenges. And so if one takes race in the center, it is clearly impacted by education, and education is impacted by race, which is also then impacted in a bidirectional fashion with unemployment. Health access is driven by unemployment because insurance certainly facilitates access, or lack thereof has an impeding effect. Education also is heavily linked to health literacy. With the better the educational attainment, the higher the health literacy. The higher the health literacy has been associated with a greater likely to have a certain amount of global self-efficacy and willing to lobby or advocate for oneself to pursue health outcomes. Similarly, if one looks at education and class, there is a bidirectional dynamic as well as with race and poverty. And one that is an uncomfortable conversation, and I am not trying to be politically correct or incorrect here, but I think it has to be stated that with the looming of 2035 on the horizon and the change in the demographics in the U.S., as we've seen by the rise of certain political candidates running for office, this whole issue of white privilege then adds another layer on top of this, including residential segregation. And so what we have is this unfortunate Venn diagram of a lot of competing factors, all of which influence the other, many of which are bidirectional, and further cement some of these disparities. So the bottom line is that poverty and race conspire to make HIV care and management just that much harder. And this is where we're going to talk about a couple of cases. And just to make it clear, I do not use cook cases. I think you can smell one a mile away. These are real cases. These are real people who've come to see me. In fact, one of them I just saw a week ago. So this is case one. This is a phrase that I hear a great deal from women, particularly women who are very depressed, who are overwhelmed, who have lived with their HIV infection and frankly have given up. And this was a 31-year-old Black female nursing assistant, and I remember she just walked in the clinic one day. She hadn't shown up for 6 months, and the nursing assistant came to see me and said she didn't even recognize her because she walked in with fever and she had cough and shortness of breath. But when she walked in, notice in red, she's 98 pounds. When they last saw her, she was 176 pounds. I just want to stop here for a second and ask you to think about who of you would sustain what is almost a 60-pound weight loss and not go see a doctor. Just saying. She was 103 when she came in. Her blood pressure was down to 90. Her heart rate was 120. She was 98 pounds, and she's 5 feet 8 inches tall. She had clear-cut evidence that her HIV was out of control. Her hair had straightened. She had thrush in her mouth, just the white material. She had white material on the side of her tongue, which didn't wipe off, which is leukoplakia. She had places where her skin had gone from being its normal medium brown pigment to just stark white because the pigment had been destroyed by an immune response. And when we listened to her chest, she had these loud, crackly, and high-pitched wheezes and whines throughout, and she had gotten so dehydrated that if you pulled her skin up on her arm, it stayed up in a little tent. That's what tenting means. And her first comment when I walked in the door was not, "I'm sick, I need care." It was, "I hate having HIV infection," and that this depresses her. Now, in the middle of this entire clinical debacle is this gorgeous 3.5-year-old child who comes over and sits on my lap and pats my arm and says, "It's okay, Mom, because she's going to make you all better." Now, there's no pressure here or anything. In the midst of my trying to ask her questions, she has to make a phone call to her older daughter who is at home to make sure she's doing her homework, and she looks over at me and she says, "I have to do this because our neighborhood has gotten so bad. I hate to leave her at home, but I was so sick I couldn't go home this time. I had to pick up this little one and then make sure she locked herself in because just a couple of days ago they had grabbed a child her age out of an alley and the child was found assaulted sexually and physically." So I had to ask. I said, "What happened that you couldn't come in for 6 months? Clearly you're much thinner. How fast did this happen?" She gave me absolutely no answer. Certainly I was concerned that she could have pneumonia. She could even have AIDS pneumonia or PCP. So we sent her to the emergency room for an evaluation and possible admission. And she made it really clear to me that she wasn't sure, even if she went to the emergency room, that she would come back and be seen. And I waited until her daughter was taken out by one of our nursing assistants to get her some toys to play with while the ambulance came. And I tried to point that out, that this little girl really needs you. Look how close you are. And she basically said, my mother can take care of my kids because no one will miss me when I'm gone. So this is where you're going to take your turn. So question number one, which you're going to chat your answers in now, please, is what are your top 3 fears for this patient I've told you about right now? So please do that. And please know that I present this calmly, but I can tell you that when I had to make that phone call to the emergency room, I had to hang up 3 times because I was crying so hard on the phone. The admitting nurse in the George Washington ER could not understand me. So I'm going to ask you to chat these in. And while you're doing that, just think about some of these other things. That this is someone who clearly poverty and race have conspired to get her into a tight jam. So start thinking about how you think these have conspired to get her there. And at the same time also why she won't commit to returning to care. Remember, she went from 176 to 98 pounds, and she did not come back. So let's go on to this. I'm going to ask you to do a poll for me quickly. How have race and poverty contributed to her issues now? You can choose from affected her job options, affected her living options, affected the partner choice, all of the above. I'm going to take a second here and let you to do that. And then, Brent, I'm going to ask for some guidance here. It says here, skip to the results. Can I wait another second? Oh, here they go. Well, see, I can actually go back to my next meeting. You all are expert in this. It's exactly right. Everything. These have all conspired, and this is what we see every day, isn't it? That it's this complex interplay that leads us to be in a really tight jam. And why won't she commit to coming back? Do you think it's because she's got job home pressures? She did tell me that she couldn't come earlier because if she didn't go to work, she wouldn't get paid. We hear that a lot. Is it because she's depressed? Is it because she's overwhelmed? Do you think it's all of that and even more? So just take a moment to give me your thoughts on that. By the way, I'm looking at some of these answers. Thank you so much. These are just superb. These are just superb. That's right. It's exactly right. I really felt very strong with all of those. And can I just take a moment here to say that let's also remember that she's overwhelmed and depressed. And as providers, we're not immune from that either. So here I'm looking at this and I'm overwhelmed, obviously. I mean, I couldn't even talk to the emergency room nurse. I had to hang up. So she did go to the emergency room and she was diagnosed with, of all things, bronchitis, which was shocking because I just knew she had something horrible, which is a good lesson. Even though people can come in profoundly immunodeficient, they can still have same old garden variety things that everybody else has. I did call her mother, and I found out that her changing appearance had led her job to be a lot more, shall we say, vigilant about what was wrong with her. And she felt some pressure to continue to hide her diagnosis. That there was a child in her daughter's class, one I mentioned, who was molested on the way home, and her mother, obviously is watching this happen, thinks that her daughter has developed worsening depression, and she's expressed the need for help with the children. Brenda or someone, do you want to read to me some of the things we heard in terms of people's top 3 concerns for this patient?
Sure, certainly. Let's see. So it was mentioned that she will die. Another concern is her health, lack of concern for self, that she will commit suicide, will not get medical care, that's CPS involvement for her children. Again, somebody else mentioned suicide risk, failure to thrive, painful death, depression.
Those are all excellent. And can I just say that for people who mentioned suicide, what do you think she's doing now? Suicide by HIV, and I've seen it more than once. I actually spoke at a funeral of a patient who was very successful at that. She just basically didn't take her pills. No matter what we did, including pretty much directly observed therapy, after she died, we found 65 Truvada pills in the plant next to her bed in her mother's home. So unfortunately, this is in and of itself a form of suicide. But those are all excellent, excellent answers. That's exactly what went through my head. And Child Protective Services was right at the top of my list because I'm thinking if you're not taking care of yourself, I don't know what's going to happen to your children or if you're even taking care of their needs. We did get them connected to a case manager who already knew the family because she knew the patient when she was pregnant with the little one in the office. And she surprised me because she said, you know, Dr. Cargill, I don't recognize her because this woman was 100% adherent when she was pregnant. Her biggest mission was to have an HIV-negative baby. So when she came back for follow-up, she looked like a totally different person. She had gained 15 pounds. She had makeup on. I'll never forget that. She was taking medicine. She was chatty. I had given her mother, but I also gave her my cell phone number, my office number, and my home number. I really wanted to make sure that this young woman had access to us at all times. A few months go by. She misses her appointment. She missed 3 of them. But I had her phone number, so I sent her text messages. She did not respond to me except one day to say, I think my medication's causing me to have low blood or anemia. So I said, that's possible, but I don't think that's likely. It's more likely how far your HIV is advanced. If you can stay with us, we can get your blood levels to recover. And I made arrangements for her to drop in at any day after work. She didn't need an appointment, nothing. They knew when she showed up, put her in the lab and get her blood drawn. She didn't show up. She still didn't show up. I sent her text message after text message because she didn't want anything sent to her house. Until finally, when I went to send her one text message, I got a return notification from her carrier that she blocked my text messages. And that was 5 years ago, and I have never seen that woman since. And I suspect she may have passed away. So what do we learn from this? I think whenever possible, what we already know, that you're going to need a team to help you with this, not just team from within your agency, but people that are important to the client within their social network. Once I knew that Mom was helping out so much, she became an incredible ally, but unfortunately Mom couldn't move her either beyond a certain point, and she seemed to be, for lack of a better word, almost overwhelmed or bowled over by this patient. I also learned from this, and what I want to make the case for, and it's been shown not only in our work, but there have been HRSA studies and special projects of national significance that show if there's a way to make an active referral as opposed to a passive referral. A passive referral means handing someone a piece of paper. An active referral means you either take the person, you've called ahead for the person, you've given identifiers so that person knows they are expected, i.e. if you don't show up, you will be missed. And that was what I was trying to do in my 4 attempts to reach out to GW. In fact, one of the reasons when the patient returned, I asked her, you didn't come back before, why did you return today? And she said to me, the nurse that took me in said to me, you must have really looked very sick because someone at that clinic was so upset I couldn't understand her. She was crying so hard on the phone. So obviously people worry about your care, and you need to worry about your care too. And that was one of the few things that impressed that patient, that in our practice we were worried enough and cared enough about her that we not only kept calling and made sure that her daughter got home, but that someone was so choked up that they felt it was a tragedy to see her this ill. Unfortunately, it didn't carry over. Case managers, primary care providers, social services, we already know this. We all have to work together, but if your office is like mine, sometimes we work together beautifully, and sometimes it's a turf field, and sometimes it's like 5 blind men and the elephant. Everybody's got their own corner of it, and they think that's what it is, and it isn't. It's the whole picture. Certainly being creative is essential. And sometimes we have to be like Sherlock Holmes. I did a lot of digging around with this young woman and discovered that she was actually living with a husband who was supportive, but she was sexually unavailable to him and was often very hostile and gruff with him, and he felt he was caught in a bind. He didn't want to make her feel like he would leave her, but at the same point, she was often so difficult he feared for the child and so stuck into the home mainly for that. It was a very complex and very difficult conversation. Obviously, some of the things we do, we always have to be aware of the limits of patient privacy and what people agree to. But the one thing I learned from this is that I had to really go out of my way and be willing to invest the extra time, to do the digging, to contact the people in the network, to go talk to the case manager and say, wait a minute, you knew her back when, before she had this child, and yet she was adherent here. What's changed? Something must have changed, and try and dig around and put the pieces together. So let's go to our second case. Because I want to leave time for questions, we're not going to have as much polling, but you'll have a chance to have some. This is Rana. He's a 35-year-old man. He came to the office because he'd had diarrhea for 3 weeks, and he hadn't come before that, even though his provider, who was a colleague of mine, we worked together in the practice, had been looking for him because he said he had just found a job that he liked, and the staff liked him, and he didn't want to call in sick because he was afraid he's going to lose his job. And so when I talked to him, I discovered that he was supposed to come in. He didn't. He supposedly didn't have the time, that he lives on his own, but he was very close to his mother, who really embraced him. She embraced him. She embraced his sexual orientation. She was supportive as he coped with his HIV infection. She made sure that he knew that he was still precious in her sight. Did not matter that he was a gay man, he had HIV infection, whatever. And all too often, our patients don't have that. So he was very fortunate in that regard. But when he came in, I mean, although he was pleasant, he clearly was weak. His heart rate jumped up when we had him stand up. His blood pressure was low, and he even said, he confirmed this, that yes, I'm dizzy if I stand up. So thinking quickly, because he kept saying this job meant so much to him. He had been unemployed for 4 months. It was a contract job, so he didn't have any job security per se, but if they liked him, they could convert it to a full-time job. So thinking quickly, I went down. I had the nurse practitioner go downstairs and get Gatorade, because we usually keep it in the practice, but we're out of it. Had him knock back a couple of liters of that. We got him a bunch of tests. I talked to his job. I had his permission. I called the job, and I just said to them, you know, this young man has had an unfortunate episode with some viral illness just covering for him, and he'll need to be able to have frequent bathroom breaks. I'm writing a note to that effect, but I wanted to give you a heads up, and I agreed to see him in 2 weeks. So he came back in 2 weeks. He looked great. His diarrhea had stopped, but then at Christmas I got a phone call. All of my patients, by the way, parenthetically have my cell phone number, much to the chagrin of my fiance, but that's all right. Things fell apart at Christmas. His mother had a stroke and developed a complication and was hospitalized, and he was told by his employer, I understand you need to take time off because you want to be with your mother, but at this point you got to choose. Either you come to work or you stay by her bedside, but if you stay by her bedside, stay there because we'll fire you, and that's what he chose, and he got fired. And to make matters worse, his mother died on Valentine's Day. So he fell off the wagon. He dove headlong back into crystal meth, went back to an old lover who told him that he was not interested in any kind of permanent relationship. He was only interested in unprotected sex and partying, and he could either take that or leave it, and so this is what he chose. And I called him. He didn't answer me. I sent letters. I got nothing. So I pulled my last adherence trick short of my showing up. And by the way, if I show up, it's a problem because my license plate says bug, B-U-G, doc, D-O-C. So, you know, if I roll up in front of your door, you might have some explaining to do. So I usually threaten people, I'll send you one last FedEx. Then when I show up, I'll leave you to explain to your neighbors while the bug doc rolled up. So anyway, I sent him a FedEx, and I tried sending him a FedEx every week for 3 weeks, and he came back. And before I could even talk to him, he says exactly what you see here. He cut me right off. He said, could you just not care about me for a minute and let me tell you, I'm just so ashamed. I've done everything and anything. I got drunk and I got kicked out of this hotel downtown in Washington that's known for these drag queen parties on New Year's Eve. My boyfriend told me that he doesn't want me for anything except for sex and fun, and if I want to be serious, he's not interested. And here's the piece that I hadn't heard so clearly articulated that he said to me. He said, Dr. Cargill, I did everything I was supposed to do. I went to college. I graduated. I made sure I learned how to speak English well. I am a well-mannered young man. And to this day, I still can't get a job since I lost this last one. My mother died, and I can't even pay my own damn rent. It was his mother's sister, his aunt, who had made a commitment to his mother to watch out for him, that was covering his rent. So now it's your turn, because there's just so much to do for this young man. Rana's just like everyone else that we see. So this is where you get to chat your answers in. What are your top 3 priorities for him right now? So please chat those in. And while you're doing that, I'm going to answer some of these other questions that are more rhetorical than anything else. We could all probably answer them. Obviously, poverty and race have conspired to get him into where he is now. He has not been able to get other than contract jobs for reasons that aren't completely clear to me. I did have a conversation with him, and he has passed drug screens, so it's not like he has a past history of drug use that he's been caught at. He certainly does have it, but he's not been caught. And he's been very much worried about his housing. He's worried about his counseling. He has a very low sense of self-esteem. He's very upset he's gone back to this gentleman, who, gentleman is a nice word, I guess, who has treated him so poorly and made it very clear that all he really wants from him is sex. And he's focused on the fact that he's got someone outside himself paying for his rent, and he wants to be able to work and do for himself. So I'm going to stop here, and Brenda, can you please read some of the things that people have chatted in for me, please?
Yes, let's see. Someone mentioned that he is a high risk for suicide, concerns about medical adherence, housing, counseling, drug treatment, being treated aggressively, depression, safe sex, and self-motivation. Mm-hmm. Also concerned about his lack of self-esteem and self-care, homelessness.
Right. Well, those are all very good, and so I'm just going to tell you that that's exactly where we were. Clearly, because he's not been paying his rent, someone else has been paying it for him, but he's just very upset and he's afraid he's going to be homeless. So getting him rent assistance or some housing is a priority. And I found out that his aunt not only was covering his rent for now, but she had no intentions of not doing that, that his mother had allowed for her to have access to some funds that would cover him. So his housing was stable, so I felt I could take a deep breath. Depression it is the biggest single predictor for treatment failure, as well as people aptly point out suicide, but non-adherence, drug use, all that. He has been in therapy for some time since he came out, so I made contact with his therapist, and they saw him on an urgent basis, and now his therapist and I talk together as well as individually to Rana. He'd had lots of unprotected sex, and it's really interesting that everybody has talked about substance use and all that, but let's talk about the fact that one of the fastest ways to run the immune system down a rat hole is to have an untreated sexually transmitted infection. And as a gay man, particularly syphilis and hepatitis C should come to mind. And so, in fact, we did get blood, urine, penile, all sorts of swabs. Basically what we told him was we call him around the world. And I just saw him 2 weeks ago, and not surprisingly, he is now being treated for his third round of syphilis. He very much wants to work. We did have case management and social services working with him for jobs. I also went and took a look and ran job searches for him. We've talked. He had 3 interviews. Unfortunately, one of them was on the telephone while he was waiting to see me, and when I came in, he was quite upset, because his first comment was, I've run into my first homophobia straight-out encounter. And I asked him what happened, and basically he called the place. They were very interested when they saw his paperwork and his qualifications and certifications. As soon as she spoke on the phone, she said, I think we weren't clear with you. You really need to have your clearance through Homeland, not through Homeland Security, but through Defense. And he said, I point out to you Homeland Security is over Defense. And her response was, well, before I waste your time or mine, let me look at your papers and your clearance again, and I'll get back to you. And we both knew she wasn't going to call him back. He has a ton of family support, so I use this with his therapist to get him over some of these hard times. He's also incredibly lonely. That is why he's tied up with this partner. He's grieving. He talks all the time about what it was like to watch his mother slip away from him. He was there when she passed away, their last conversation, as he said, when she closed those beautiful gray eyes of hers and went to sleep. He self-medicates, and that's one of the biggest things that has to be acknowledged, and he has to acknowledge it, that he's self-medicating, whether it's alcohol, marijuana, or in this case, crystal meth. When I just saw him in the practice last week, he had been crystal meth-free for a month and a half. He did get back to his case manager. I had to update this because we ran a second serology, and as I told you, it's positive for syphilis. He has kept the one visit, but he just sent me a text message before this presentation telling me that he has another job interview, and so he's going to probably have to miss this appointment this week. And I remind him that the treatment of syphilis in his case is 2.4 million units of penicillin every week without fail, and if he fails to show up, then the disease intervention specialist has to come and knock on his door. So we're getting close. I want to leave time for questions. So I just want to leave you with a couple of take-home points. And I love this quote from Vernon Sanders Law because I think it's so true. It's been true as I've learned how to care for people with HIV infection. It's been true as I've watched people make mistakes, including me, my own children, my patients, that experience is a hard teacher because she gives the test first, and then she gives you the lesson afterwards. So that what I've tried to show you is that race, poverty, and education, and all these other social determinants just impact health risk, HIV risk, acquisition, treatment, care engagement, that there are a lot of complex and very convoluted links that mean that there are a lot of challenges that our clients as well as us who help them face, and we've got to get creative. And I've used some pretty unconventional out-of-the-box approaches, but desperate circumstances call for creative responses. And that we can't be siloed. I work for the federal government. You can't talk about a bigger silo than that, and yet we've got to reach across those so that we can be much more woven as a network. And there's no incentive to do it, and sometimes there's actually disincentives, but we have to find ways around it. We can't do everything at once, and so I try to think of a pyramid and that how can I build sort of like the house that Jack built so that I can put one thing in place. Like with Rana, once I knew his housing was set, I could get off that dime and put my attention to something else. Was how can I get this young man's head back in the game, which means really working with his therapist and dealing with his relationship or the need to get rid of this guy. And then once we can get to that, what about work? And how are we going to get work part of that? Because that's clearly part of his way he builds his self-esteem. And again, as I said before, the support of family, friends, and peers. His cousin came to him and said, I don't care what you've done, who you're with, whatever, you'll always be Rana to me, and I really need you to help me through this next life event. She is getting married to someone that they've both known since they were children, and this was going to be a big family deal, and said, I completely trust you, we'll pay you, but I need you there to be there for me. And that really made him feel needed and kind of snapped his act together that he's been 100% available to her and helping her handle this. As I said before, active referrals beat passive ones every time, and we have to try to find ways to get people's attention. There have been multiple studies that have shown that sometimes text interventions or other sorts of interventions work better than the straightforward letters because people have learned to blow those off. And I think the biggest lesson that I had to learn, I continue to learn, and that we all have to learn is we don't win everything. And that sometimes, even though we lose, we learn more from losing than winning because we learn how to keep going. And I've had to remember this when I've lost patients, and I have lost them still in 2016, not because our pills didn't work, but because they were tired and they just didn't want to take them. So I'm going to stop there, and I guess I'm going to leave the rest of the time so that we have questions, and Brenda, I'll turn it back to you.
Yes, Vicki, at this point we're still waiting for questions to come in, but I'm wondering if you can speak to any community collaborations that you've been involved with to address the issue of poverty.
We're fortunate that in Southeast D.C. there are a couple of community-based organizations, and there have been a couple of things that I've done. We had a real uptick in young women who were presenting with HIV infection who were completely unaware of their HIV status. And I had just been in Ohio to see a play, and it was a play about two women on two different parts of the world who find out they're HIV positive and pregnant at the same time. And so I was able to work with the Ward 8 Coalition to bring that performance troupe to Washington, and we were able to do 3 different shows. And our clinic mobile testing van was there as well, so that after the performance, the mobile testing van would be there for women who are interested in being tested. And my chief, because I tried to impress upon him what we were seeing, was so moved by this, he actually helped underwrite the cost of being able to have pamphlets, educational material, and actually food there for women in homeless and domestic violence shelters to come, so that everybody could come and see this play in the continuum, take the message away, and at the end be able to get their HIV testing. And we uncovered something like 14 or 15 new positives just between 3 shows. So that was really something. Another thing I've done is I work very closely with medical case managers so that they've been extremely helpful for us. And we have a number of medical case managers in our practice. Actually, our practice, we have them not only in the practice, but we have them housed in some of the churches around the practice as well. So that sometimes people don't want to come into the clinic to see the medical case manager, but they will go to another less, quote, identified. So that's something that I think was a brilliant move by the practice. I had nothing to do with it, but it's often been very helpful to be able to say, you don't have to come back into clinic. You could go to the church down the street, or you can go to da-da-da, and there's a case manager there who can help you, and they link right into our health information system.
So I just wanted to let everyone know, please feel free to chat your questions in. And then, you can just, whatever questions you have for Vicki, please, you can chat them in the chat box.
Well, it looks like I see when I answered the one about do I work with case managers, one would be what would be helpful for providers to include as part of their services. I think it really I don't know that I could give you a blanket, but one of the things that repeatedly has been shown in the literature and in our studies and in our clinical practice as well is the more one-stop shopping people can do, the better it is. I worry when I tell someone, well, I know that you need grocery and we have grocery assistance here, but the person who handles that isn't here today, and so I need you to go down to X because my fear is they'll never go to X. The best thing that ever happened was when I could say to someone, I know that you need food and you need food assistance and you're not going to leave this practice today hungry, and we can actually walk them downstairs to the second floor and go to our food pantry and be able to go home with a couple of bags of groceries. I mean, it seems like a small thing, but if you've been hungry, it's a huge thing. Or one of the things that I'm very aware of when people have dental issues, we can't provide dental care if we don't have a dentist on site. There's a practice up the street from us that does provide dental care. But one of the things that I was unaware of that one of my patients advised me is that when she went to get dental care, she was asked if she would then sign off so that all of her medical care would transfer to them. And when she was unwilling to do so, her welcome mat got rolled up and she was unable to get her dental care. And this is a woman who had a periapical abscess, a glucose of 800 that I'd already sent to the emergency room to get insulin be monitored, and they booted her out. So I gave her huge props for that, because I'd have sold the kids, the house, my car, anything just to get out of pain. But she wasn't going to leave the practice. And so I'm very acutely aware that the more one-stop shopping we can do, the better. Someone's asking about Andy's change. Sorry, go ahead.
Oh, no, I was just going to say that we do have some questions that came in. One of them is...
I'm reading them and going through them. Yeah, go ahead.
Okay, so I can just ask them out. What are your thoughts regarding what can be done to improve outcomes?
Again, some of the things that I talked about, and this has been actually studied and looked at, one-stop shopping is very helpful. Active instead of passive referrals. HRSA has a special project of national significance which has been replicated, demonstrating that for those practices that can hire or have a retention specialist, someone whose whole job is to go after people who don't show up, the one study they did with a retention specialist, that retention specialist was able to recover 114 out of 162 missing people. I think they pretty much paid their salary. So those are some of the things that can be done to improve outcomes.
Okay.
Go ahead.
Do you have any suggestions for case managers who meet resistance from medical providers in collaborating?
Yeah, that's really hard, isn't it? Because medical providers can really be jerks. And I count myself in that as a physician. I think one of the things that is very helpful to remind that, if you can, that people are multidimensional, and there are things that people will tell the case manager they won't tell the provider. And there's a very robust literature on this. In fact, there's even been a study done where people will tell an ACASI, which is a computer-assisted questionnaire, they'll tell them things they won't tell the provider, and the provider only gets to see the answers after the visit, so that it's in the provider's best interest, because you're not trying to take that provider's job. You're actually being able to be a service provider to get information they may need to help improve outcomes, and perhaps coming at it that way.
Okay. Do you see any of these changes being made nationally in the near future?
Yeah, if you go and look at the national HIV care strategy, that's been updated recently, and a lot of this has been written into this in terms of, what are some of the other outcomes, not just benchmarks like number of people who know their status or people being retained in care, but what does retained in care actually mean? What does this mean in terms of the kinds of outcomes, in terms also including community viral load, people being on therapy and having a response to therapy?
Let's see. Do you have good access to mental health?
Absolutely. Absolutely. We have mental health both within the practice, and we're ringed by mental health providers outside the practice, and many of our case managers are trained to do preliminary basic counseling and then move on from there. So, yeah, that's something that we're really very fortunate. We also have adherence counselors. So if I have someone that's not adhering, I can stick the adherence counselors on them. And we also have an introduction to HIV care group, so that sometimes people just aren't really ready to get into care and get into pills and what that's going to mean. And so there's a focus group that's led by just a wonderful case manager. To tell you how wonderful she is, there was a blizzard and the clinic was closed, and she was afraid she couldn't reach people, so she went to the clinic anyway. So anybody who showed up, she could try and get back home. And her whole group showed up, so she ended up having group down the street because it's a way for people to talk about all the fears they have about treatment. What is it going to mean? How is it going to impact my life? And she's very committed to that group, and she runs that group. She runs like a group every, I think, 3 months they run them.
Let's see. Is it a myth that an overweight person cannot be HIV positive?
It absolutely is a myth. Rana, the patient I last presented to you, is 5'5", and he weighs 285 pounds.
With the correlation between poverty and higher rates of HIV, should the education be introduced with sex education as early as during middle or high school?
Oh, absolutely. I'd say even earlier. I started an AIDS education organization. Stopping AIDS is my mission, which is still in existence. And SAM was started in 1998. It's now being the executive director is the first teenager I trained, which makes me feel really old. And in fact, it is in the schools, and it needs to be at the middle, high school, and I would submit even the upper elementary school, since when we first started it, one of the reasons I started was not just the drug traffic and the resistance by some of the schools to have me talk about it, or some of the, for lack of a better word, almost bullying I took from some of the male teachers. Oh, nobody wants to hear about HIV unless you're a punk, code for being gay, which of course is not true. But in our practice, one of the youngest patients I took care of was 15, and she had probably acquired her HIV infection at the age of 14, and she advised me that she now had a cousin who had acquired HIV infection. That cousin was 9 because she was injecting with her mother. So you really can't start too soon, because we make a lot of assumptions. And I'll just put myself here. I'm aware that I make a lot of assumptions, whereas my assumptions are from my cultural context and where I've come from, and I need to be better about having that lens that Meredith Minkler talks about of cultural humility, where I can look at it through the lens of somebody else and realize that their approach to it could be 150% different from mine, and I got to be on board with that.
Hey, Vicki. Let's see. Are you aware of any programs providing support and education to women with HIV/AIDS with no regard to income, socioeconomic status, etc.?
Yes, there are a number of them. I know them here in our area. I don't know them around the country, but yes, there's like the Positive Women's Network. There's also another one's group that just went out of my head right now that was started by a woman living with HIV infection, and it's a large group, and they provide a ton of support and outreach, including even getting them linked up with folks that can help them with housing and other things. So yes, there are.
Have you noticed a decrease in drug addiction and sex workers in your practice?
No. In fact, if anything, we're having a brown heroin kicking our butt problem out here running between Baltimore and Washington. You may or may not have heard that the resurgence of drug overdose deaths in Baltimore has really made it a crisis. And for example, in Baltimore, people are given buprenorphine. I mean, addicts and shooting galleries are given buprenorphine because it became so bad. So, no, we continue to have drug addiction and commercial sex work in our practice.
Okay, we have a multiple-part question here. How do you deal with patients that have mental health issues in addition to being HIV positive and have a number of other medical health issues? That's part one. Also, has there been a resolution to the Mr. Dietz case and his situation? And the last part is there more financial aid from the government for you to work out some of the above issues?
Well, let's just take them in order. I have patients who have mental health issues as well as having underlying health issues. I saw one last week. She has severe post-traumatic stress because she acquired her HIV infection by minding her business, walking down the street to get an ice cream for her mentally challenged son, and was grabbed off the street by a group of men, put in the back of a car, taken to a house, raped, and then thrown back out in the street and told she wouldn't be harmed, and they promptly shot her and left her for dead. So now you tell me how you come back from that. But she takes her medicines faithfully. She now, we have discovered, has comorbid hepatitis C infection, and so we're trying to get her on program and registered so that she can go through Harmony treatment because it is quite expensive. I don't know the Mr. Dietz case unless you're talking about Rana. I don't know what that is. In terms of financing, one of the things that is clear is that there's going to need to be more primary care providers in HIV care. There is a shortage of infectious disease people to take care of people with HIV infection. I am not an infectious disease specialist. I learned this on my own time, own dime, when I came around and the first patient with HIV crashed when I was just straight out of training, so I learned about it then. And I think that covers that one.
Yeah, I think, let's see. They also asked if there was a resolution to the Mr. Dietz case.
I don't know that case. I'm sorry. Is that the patient I presented?
Yeah,
I think what? So. Oh, okay. Yeah, he actually sent me a text. He does not. He wants to continue to get his medicine. He wants to take care of himself. He actually told me in his text he's gone back to church. He got rid of this boyfriend. I've told him a number of times how incredibly proud I am of him. I knew that his mother's death anniversary was coming up, for example. So even though I hadn't heard from him, I just sent him a card with a little box of chocolates. I know at $2.85 he doesn't need chocolate, but you know, hey, sometimes chocolate fixes things. Saying, I'm thinking of you. I prefer that I could see you. And he came back in about a month later. So he is doing much better, but I consider him to be one of my more tenuous patients, even though he is one of my more vocal and grateful. And frankly, I worry more about him committing suicide than I worry about the young woman who didn't show up, because she was already doing it by not getting care. I'm worried about him actively deciding one day he hasn't had enough, and he's had enough, and he's just not going to take it anymore. And that's a worry I have for him, especially with his depression.
Let's see, what short-term and long-term life and health improvements are possible with AIDS medication? What is the survival rate?
Oh, my goodness. We've done so with HIV medication. In fact, this has been published that if people are adherent with their HIV medication and get into care and have any kind of intercurrent illnesses taken care of, we're right now looking at people who would become infected with HIV and taking their medicines completely. They have a near normal life expectancy. It's probably cut now by about 10 years, but really not a way. It's not like it was before where you took these pills and eventually don't work and everything's, you're just out of luck. There are people I started treating 22 years ago that are still around, and we laugh about, we laugh now, we couldn't laugh then, that we both thought we were going to be having to have a lot harder conversations than we are now, which include how do I file for Medicaid, Medicare. I mean, who thought they were going to live to be that old, but they did. So yes, you have tremendous potential for life expectancy, but you must take the pills, you must get into care. When you don't do that, all bets are off.
Would you say that abstinence is the best practice for prevention of becoming infected with HIV?
I can't say that, because I don't think that's a realistic expectation, because then you're saying then people don't want to have children. What I do say is that it is a multimodal approach. People have choices, and people do better when they have choices than when they're told you can only do X. So I have the same speech. I've had it since the beginning of the epidemic. If you can, you should abstain. If you can't, you need to be monogamous. However, we have to be careful, because the first woman I lost to HIV was a woman who was completely monogamous to her husband. Unfortunately, her husband was monogamous with her. So you have to be careful. And then see, one should use condoms. And the other thing that's coming around the bend that's very helpful is pre-exposure prophylaxis. And we could do a whole separate talk about why providers don't tell their patients about pre-exposure prophylaxis, why it's hard to get people to take it, how do you have to take it, what we can achieve with it, because done right, we're looking at 97% protection. And then what's coming down the pike for pre-exposure prophylaxis, drugs like cabotegravir, which may allow us to give somebody a shot once every 2 months, and that's the end of the discussion. So I don't like to be absolute about a lot of things. I like to say that depending on the person's life circumstances, there are options, and they need to use them.
Okay, let's see. You mentioned a bit about texting patients. Can you tell us the reference on that being a good way to reach patients? This person mentions that they've been recently told that they are not allowed to text, by their hospital system.
That is a case-by-case basis. There are studies in the literature, I'd have to go back and look them up, that talk about texting as a way to do text reminders for drugs, which is what I do. I remind people, we text them as a reminder for their taking their medication. We text them as a reminder for clinic visits. I mean, my doctor sends me a text message, hey, don't forget your physical. So I think that is really restricted by the practice. It's not restricted by the literature.
Approximately what percentage of your patients are resistant to treatment?
Great question. It depends on the medication that we're looking at. Roughly 12 to 16% of people who present for the first time with their HIV infection are going to have drug resistance. About 10 to 14% of those people will be class-wide resistance, meaning there's an entire category of drug that's locked out to them. For protease inhibitors, it's less common. It's much more common for the nucleoside and the non-nucleoside drugs like zidovudine or AZT. Some of the ones have been around for a long time. The newer agents, the integrase strand inhibitors, are called INSTI, like raltegravir, dolutegravir. We see less of that, but what has been discovered is we're now starting to see isolated blips of people who have integrase strand inhibitor resistance. And so I suspect that, like anything else, because it's an infectious agent and it will figure out a way around it, and people will not be 100% adherent, with time we'll start to see the percentages of that go up. But for right now, it is not high, thank God, since that tends to be the backbone of many of our regimens. But we do see resistance, and nationally it's expected about 12 to 16% of people walk in. That is why one of the guidelines recommendations is when someone tests positive, they have a drug resistance test drawn as well, so that they're not started on a regimen that's not going to be effective and lose time. And we certainly do that in our practice. We do drug resistance testing straight up.
Yeah, just to follow up with that, Vicki, I think that they were also referencing behavioral resistance to treatment.
Oh, okay. I wasn't sure because it just said resistant to treatment. Oh, yes. I couldn't quantify that, but it's not uncommon. I've heard everything from my body's strong enough to fight this off, and I've had to say, well, then you need to tell the T cells you have left and that you can name Larry, Moe, and Curly because they didn't get that memo. We see people who say, the one that I think I was the most hurt by because she passed away, she was absolutely convinced that her having HIV infection was a punishment for having taken her parents' money, be college educated, be the first person in her family to successfully graduate college, and be really an outstanding accountant in a very prominent firm, only to become HIV infected and really fall very quickly. And so we never could convince her. I finally was able to find and track down a former co-worker that she said she felt close to, who actually came from Richmond up to the office to take her back home, but she died with her. So we see resistance across. People don't want to change their behavior. People want to take their pills. People have drug resistance. I mean, we see resistance across the spectrum, and you have to address it. You just can't go shove your head in a waste can and wish it would go away. I mean, you have to sort of roll up your sleeves and dig in.
Let's see. How long do you think before it will be before an injectable medical treatment comes out?
Well, we do have injectables now, but if you're talking about injectable for like pre-exposure prophylaxis, something like cabotegravir, there are a number of questions and problems that have to be resolved, including how long does a drug actively stay in the system? Because obviously if you give a shot, we've learned this from the birth control literature like Depo-Provera, it'll wear away and wear off. And so you have to know when you need people to come back. And just remember, if you have someone getting that injectable because they're not reliable to come in regularly, what says they're going to come back in 2 months? And now I've got somebody wandering around with a subclinical blood level of a drug they think will protect them, and it won't. So there's a number of challenges that still have to be worked out, including the drug delivery system.
Yeah, I think they're referencing HIV-positive individuals, not prophylactic.
Oh, okay. Well, we already have injectables for them, but that's when people cannot take oral medications. In terms of sustained injectable, it would be the same thing. We have to still look at how long it's going to become active and whether or not there are going to be long-term side effects of that.
What is your idea for a fix to some of the issues haunting the poor and undereducated, especially for some Blacks, Latinos, women, and children who've been the least fortunate in our society?
My God, I'm not even sure we have enough time to even begin to touch on that. I think that one of the things that and I will say this and I will say again, this is Vicki Cargill talking. I'm on my soapbox and it has nothing to do with the United States government. I think there are a lot of lessons that we could learn from Africa, but we sort of have this Western mentality that we have the answers and they have the problem. And I would submit to you that we all have the problem and the answers we can learn in both directions, not just in one. So, for example, when Africa was hit so hard, and as one of their HIV investigators once said, we had nothing but prayer and coffins. One of the things they did is they really put the clamps down on the business. So, for example, some of the diamond miners and some of the Coca-Cola companies, they were actually providing HIV care, and not only HIV care, but they were also providing support for families to be able to get their children educated, because they realized if they didn't do something for the long term, you had people dying like flies. Who was going to work your mine? Who was going to mine the fields? And who was going to what was going to happen to their progeny, who were probably going to fall into the same trap because now they were going to be left with nothing? And so I think we need to start thinking about ways that we don't just focus on the sex or drug end of how people become infected, or how our sexually transmitted infections happen, or this blame mentality. We need to think about how can we get businesses and others in the community involved so that we have a more robust community response that it's all of our problem, not just, phew, thank God I don't live over there, too bad for them kind of problem. And that's just, I think, going to be the quick and easiest.
Okay, well, since we have no more questions, I'd like to thank Dr. Cargill for speaking with us today. I would also like to thank all of the participants on today's call. We value the feedback of everyone participating in our webinars. So the link to an online survey will appear shortly. Please take a moment now to complete the form and it will be sent back to us. If you're participating on this call as part of a group, please be sure that each member of your party receives this link. For those who are interested, the next webinar in this series, Strengthening and Supporting Families, Promising Practices for Families of Justice-Involved Individuals, with Jocelyn Fontaine, is scheduled for Tuesday, May 3rd. You can find more information about our webinars at aia.berkeley.edu. Thank you.